Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Elizabeth Tubridy, and our friend and colleague, and often a frequent visitor of our podcast, and former fellow of the International Journal of Gynecological Cancer, Dimitrios Nasioudis. They're both at the Division of Gynecologic Oncology at the University of Pennsylvania in Philadelphia, Pennsylvania. And the reason for this podcast is we're going to talk about a very interesting topic, the role of lymphadenectomy for apparent early stage low-grade serous ovarian carcinoma. Elizabeth, Dimitrios, welcome to the podcast.
Hey, thank you for having us.
Thank you.
So we do have lots of questions, and as Dimitrios remembers, many of these questions are written by our fellows in the journal. But Dimitrios, we'll start with you to kind of give us a background. And, obviously it's been a tradition that patients with low-grade serous carcinoma don't need a lymphadenectomy, even when early stage disease. So can we start by discussing what is the incidence of lymph node metastases in patients with this diagnosis? And actually, what do the NCCN guidelines tell us about this particular recommendation?
Yeah, for patients with ovarian cancer presenting with apparent early stage disease, traditionally performance of surgical staging can permit adequate stage assignment and also guide adjuvant treatment recommendations. We know that from other sites like uterus, cervix, and ovary, there's no real therapeutic value of lymphadenectomy. However, it is prognostic and it can guide the adjuvant treatment recommendations. Traditionally, the recommended components of surgical staging include, of course, hysterectomy, bilateral salping oophorectomy, and mastectomy, washings, peritoneal biopsies, as well as pelvic and paraortic lymphadenectomy to the renal vein. However, the majority of the data on the incidence of lymph node metastasis arise from patients with high-grade serous ovarian cancer. Now, this emerging data suggests that for patients with rare histologies, such as mucinous, for instance, or sex-core stromal tumors, the incidence of lymph node metastasis is very, very low. It's negligible. And for these patients, lymphadenectomy does not add any prognostic value. In terms of low-grade serous ovarian cancer, it is a new entity that was established around 2004 with a binary grading of serous tumors. So the data are sparse, and it's rare. It's represents less than 5% of ovarian cancers. Given its rarity, the incidence of lymph node metastasis based on the retrospective series are mixed. There was a recent systematic review that included close to 300 patients and actually did find a relative high incidence of lymph node metastasis, approximately 12%. But again, as you mentioned, there's other data to suggest that patients with low-grade tumors that include endometrioid and serous and mucinous have low incidence of lymph node metastasis.
So now let's turn to Elizabeth. And what was the rationale for doing this particular study? Dimitrios spoke about some previous studies already exploring this question. Why did you feel the need to actually move forward and address this issue?
Yeah, so for patients with low-grade serous ovarian cancer, they can be diagnosed just following the resection of any adnexal mass. So the question of whether or not to perform a staging lymphadenectomy is not something that we come across infrequently. And we do know that staging lymphadenectomy is associated with longer operative time, higher blood loss, and a higher incidence of perioperative complications. So the question of whether or not to perform it is an important one for surgeons and for patients. Given the paucity of data of these retrospective studies in low-grade serous ovarian cancer, we aim to explore the incidence of lymph node metastases, the patterns of utilization of lymphadenectomy, and then the outcomes of lymphadenectomy for patients with apparent early-stage low-grade serous ovarian carcinoma, using a large hospital-based database that would permit hopefully meaningful statistical analyses.
Great. And Elizabeth, I was wondering if you can speak a little bit more about, your methodology, the National Cancer Database, and the inclusion criteria of your study.
Absolutely. So as you mentioned, we accessed the National Cancer Database, excuse me, and identified patients that were diagnosed with low-grade serous ovarian cancer between 2004 and 2015 based on histology codes. Those with disease that was apparently limited to the ovary who underwent surgery were selected for our analysis. We evaluated the performance of lymphadenectomy as well as the number of lymph nodes removed based on the data that was derived from the pathology reports. The National Cancer Database is a prospective database that covers approximately 70% of newly diagnosed ovarian cancer cases in the US. And we felt like that was a good starting point for our research.
Okay. And one of the first questions from one of our fellows, this one comes from Sao Paulo, Brazil, Mariana Carvalho, and she's asking, what were the criteria to select the period between 2004 and 2015 for this study?
Yeah, excellent question. So we selected this time period given the availability of survival data for all the included cases. And then in addition, low-grade serous is a relatively newly defined entity that was established following the binary grading system of serous carcinoma in 2004. So both of those were required for us to be able to answer the questions we wanted to answer.
Okay. So let's actually get on to the results, because we do have quite a number of questions on the results. So almost 1,000 patients for low-grade ovarian cancer. So a really remarkable number. Can you tell us about the results of the study, and what are some of the highlights that you would like to discuss with our audience?
Absolutely. So as you mentioned, we identified a total of 977 patients, almost 1,000 patients who met our inclusion criteria. Approximately 2/3 had apparent stage 1A or 1B disease, and then the remaining 1/3 had apparent stage 1C disease. The overall incidence of lymphadenectomy was approximately 65%. There were no differences between patients who did and did not undergo a lymphadenectomy in terms of their demographics or other clinical characteristics. And among patients who had a lymphadenectomy, the median number of lymph nodes removed was 12. And while only 26% had at least 20 lymph nodes removed. The overall incidence of lymph node metastases was 7.5% and was higher amongst those that had apparent clinical stage 1C disease, which was approximately 10%. It was about approximately 10%, or those who had an extensive lymphadenectomy, so removal of greater than 10 lymph nodes. Lymph node dissection was not associated in these cases with a higher incidence of perioperative morbidity, such as a prolonged hospital stay, increased rates of readmission, or 90-day mortality. And patients who underwent lymphadenectomy had an overall better survival than those who did not. So the 5-year overall survival rates were 91.6% for those who underwent a lymphadenectomy and 83.3% for those who did not. Performance of a lymphadenectomy was associated with improved overall survival even after controlling for confounders such as patient age, race, medical comorbidities, disease substage, and receipt of chemotherapy.
So Elizabeth, thank you for that excellent review of the results. So now I'll turn over to Dimitrios and start asking some more specific questions about the data that Elizabeth presented. This one comes from a couple of our fellows, Rima Buchakra in France and Natalia Tejeda in Barcelona. And they're asking, given that the median number of lymph nodes removed was just 12, do you think there's a risk of understaging, and could that influence how we interpret survival outcomes?
Yeah, that was a very interesting finding in our study. So the total yield of lymph nodes was very low compared to other retrospective series, and as you mentioned, the median was 12, with only 25% having at least 20 lymph nodes removed. Of course, this data derived from the pathology report, meaning that there are subjective bias and errors, of course, may not represent the extent of the lymphadenectomy performed by the surgeon. In comparison, other single institution series reported much higher lymph node yield, ranging from 25 to even 69 lymph nodes. And our data suggests that probably there's a less aggressive approach when staging patients with apparent early stage ovarian cancer in the most institutions in the United States. And this is actually similar to another retrospective study that used a different database, the surveillance, epidemiology, and end results, and found again that irrespective of histology, for patients with early stage ovarian cancer, only 60% had lymphadenectomy, and the median lymph nodes removed were 11, so comparable to our study. Indeed, we did observe a trend towards a higher incidence of lymph node metastasis among patients that had more extensive lymphadenectomy. We used the 10 cutoff and 20 cutoff, and for patients that had less than 10 lymph nodes removed, the incidence was 4.8%, compared to 9% for those who had at least 10 lymph nodes removed. So, and it does make sense. The more you look, the more lymph nodes you remove, the higher likelihood of finding lymph node metastasis. Of course, there's a limitation to our study. We don't have data on the preoperative imaging or the intraoperative assessment of the lymph nodes by the surgeon. So the patients that had limited lymphadenectomy may include patients that have suspicious lymph nodes and just had that few lymph nodes removed. But still, we didn't see a higher incidence of lymph node metastasis in that subgroup. But it is surprising, the low yield of lymph nodes, and we didn't see any temporal trends, if it's like, or any like specific factors associated with lower yields of lymph nodes.
Yeah, and Dimitrios, as follow-up to that, Luisa Prope in University Hospital Munster, she's asking with regards to this set number of lymph nodes. She says, given that a subgroup in your study had at least 20 lymph nodes resected, do you believe this extent of lymphadenectomy is already sufficient for accurate staging and optimal detection of metastases? Should we aim for even more extensive lymphadenectomy or a lesser lymphadenectomy? Can you clarify that? And certainly, do we drive at least achieving this 20 lymph nodes resected?
Yeah, I think the number of lymph nodes there's no specific like number, because there is patient anatomic variations, right? The yields can be low in certain patients just because of their anatomy, not because of the less aggressive surgical effort. I think what really matters is not the number, but whether the lymph node basins that are at risk have been thoroughly evaluated. And that, of course, includes the parotic area, which is higher yield compared to like the pelvic area, the contralateral pelvic area, for example. So it has more to do with which basins have been evaluated than just the yields of the lymph nodes.
And then now, question from Helena Obermeyer in Sydney, Australia. And she's asking, in your study, lymph node metastases were identified in 7.5% of patients, yet 30% received adjuvant chemotherapy. So do you think that nodal status is really meaningfully influencing treatment decisions, or were there really other factors that perhaps were more important that drove adjuvant therapy?
Yeah, based on the current NCCN guidelines, adjuvant chemotherapy is standard of care for patients with stage 2 and above disease. And even though this question has been currently valid in a prospective randomized trial, our understanding of the chemosensitivity and the benefit of adjuvant chemotherapy for patients with low-grade serous ovarian cancer has really evolved for the past years. And low-grade serous overall as an entity is relative chemoresistant. And for patients with early-stage disease, based on the current NCCN guidelines, chemotherapy is not recommended for those with stage 1A or 1B. However, for patients with stage 1C disease, both observation, adjuvant chemotherapy, and hormonal treatment are all acceptable options. So we did see that in our study, patients that did not undergo lymphadenectomy are actually more likely to receive chemotherapy. So we think that the decision to administer chemotherapy is multifactorial and may vary between different institutions and may vary between different time points, given the evolving data for low-grade serous ovarian cancer. Unfortunately, what we don't have, which would have been more important, is the data on the administration of aromatase inhibitors like letrozole or anastrozole. And these, given that low-grade serous consistently expresses estrogen receptors, administration of these agents may have actually impacted survival outcomes in a more meaningful way.
Excellent point. Really good. So let's actually turn over to Elizabeth, and this question comes from Natalia Tejeda. She's asking, the authors of this article suggest that the overall survival benefit of lymphadenectomy is likely due to stage migration. However, in the literature, the proportion of patients upstage due to lymph node metastases is usually lower than the observed rate of nodal involvement. Do you have information on how many patients in this cohort were truly upstage based on lymph node findings? And were data on other potential sources of stage migration, such as omental or peritoneal results, available to clarify their contribution to treatment decisions?
Yeah, in a recent meta-analysis of available data from patients with apparent early-stage low-grade serous ovarian cancer, the rate of upstaging due to lymph node metastases alone was about 10.5%, 16 out of the 153 patients included in that study. In our study, we selected patients who, in the absence of lymph node metastases, would have been assigned stage 1 disease, T1. All patients who had surgical management, however, like the information on the extent and the thoroughness of staging procedures, so washings, omentectomy, peritoneal biopsies, was not collected, so that question remains.
Yeah. Question from Sofia Bigardi in Padua. And she's asking, since most nodal metastases were found in patients with extensive lymph node removals, could nodal positivity in low-grade serous ovarian cancer reflect the extent of the sampling, or how should this affect our view of lymphadenectomy as prognostic and as a therapeutic?
I think it's a really interesting question. So, as we mentioned, we did observe a higher trend towards incidence of lymph node metastases among patients who had that more extensive lymphadenectomy. And then the incidence of lymph node metastases among those who had less than 10 lymph nodes removed was 4.8% compared to 9% in patients who had at least 10 lymph nodes removed. I don't think we can draw a conclusion based on the extent of sampling reflects nodal positivity and therefore stage based on this data alone. And while lymphadenectomy in high-grade ovarian cancer for presumed early stage disease is thought to be prognostic rather than therapeutic, our data does suggest the survival benefit is conferred by performing a lymphadenectomy in this low-grade serous ovarian cohort.
Yeah. Elizabeth, I want to turn now to surgical approach. And this question comes again from Luisa Prop. You mentioned a significant proportion of minimally invasive procedures. Did the surgical approach, open versus minimally invasive, impact lymph node assessment or patient outcomes?
So the data from this data set on the surgical route of the staging procedure performed were only available for half of the patients. So we don't have the data for all of the patients included in this cohort, and approximately 40% of the patients we know the route underwent minimally invasive surgery. The rate of unplanned readmission and prolonged hospital stay, which is defined as 10 days, were comparable between those two groups. And the rate of minimally invasive surgery was approximately 40.6% in patients who underwent a lymphadenectomy compared to 38.2% in those who did not. So among patients who had a lymphadenectomy, there was no difference in the among those who had a lymphadenectomy, there was no difference in the number of lymph nodes that were resected when comparing MIS and open approach.
Okay. Now, Dimitrios, the question from Mariana Carvalho is asking about a point you raised earlier. Do you have any information on anti-estrogen maintenance therapy? Do you think the proportion of patients that receive letrozole, for example, could change the study findings?
And we don't have reliable data on the use of anti-estrogen maintenance therapy, unfortunately. And this is a limitation, especially since on the NCCN guidelines, it is recommended for patients with stage 1C disease. And as we discussed before, 80% of low-grade serous ovarian cancer expresses estrogen receptors. And we know from retrospective series that use of anti-estrogen maintenance treatment does prolong PFS and OS for patients with advanced stage disease. So this is a good question, and unfortunately, we don't have the data to see the interaction between lymphadenectomy, lymph node metastasis, and use of anti-estrogen maintenance treatment that could have influenced our results, and of course influence the decision to perform a lymphadenectomy or not.
And Dimitrios, as a follow-up to that, as a clarification also for our audience, is that data that can be obtained from the National Cancer Database, so that the drugs that the patients were on?
So the specific drugs are not available. So there is a variable that includes, for instance, chemotherapy, single agent or multi-agent, but the specific drugs are not available. And the data on the hormonal agents are very weak and not really available. And sometimes there's no discrimination between maintenance and use of adjuvant treatment. So they're not reliable as compared to chemotherapy, but the specific drugs are not available in the National Cancer Database.
Excellent. All right, very well. So turning back to you, Elizabeth, Sofia Bigardi is asking, based on your data, how could the improved survival associated with lymphadenectomy in stage 1C be influenced by the routine use of adjuvant chemotherapy in this subgroup?
So when we performed the survival analysis stratified by disease substage. So performance of lymphadenectomy was associated with an overall survival benefit for patients with stage 1A or 1B disease. So 5-year overall survival rates of 92 compared to 85%. And for patients with 1C disease, the lymphadenectomy was associated with a trend towards improved overall survival, with a 5-year overall survival rate of 90.9% compared to 80.2%. So the lack of statistically significant benefit in that cohort of stage 1C patients may be attributable to sample size. So 385 patients with 62 events for stage 1C compared to 592 patients with 87 events for stage 1A and 1B. And then the higher rate of chemotherapy use among patients with stage 1C compared to stage 1A and 1B was 55% got chemo versus 15%, which is very statistically significant. So interestingly, among patients with stage 1C disease, the rates of chemotherapy administration were comparable between those who did and did not undergo lymphadenectomy. So that's an interesting point as well. However, like we've mentioned before, the use of hormonal maintenance may have also been higher amongst those who had a lymphadenectomy, given the identification of lymph node metastases. So another point that we can't really speak to.
Excellent. So now, Elizabeth, I was wondering if you can highlight and outline some of the limitations of the study.
Absolutely. So firstly, given the absence of a central pathology review, there's a possibility that histology or staging misclassifications could have occurred. Moreover, the data on tumor relapse or the cause of death was not collected by the National Cancer Database, precluding us from evaluating the impact of lymphadenectomy, on progression-free or cancer-specific survival or patterns of relapse in these patients. The results of radiographic or intraoperative assessment of the lymphatic beds is also not provided. So like we mentioned earlier, we don't know what the surgeons had in terms of the information going into the OR. And in addition, specific details of the surgical procedures performed. So the location of the lymphatics that were resected, pelvic, upper or lower para-aortics, the laterality, the upper limit of the surgical dissections, and other factors like total operative time, occurrence of intraoperative or postoperative complications, and blood loss are also not collected by the National Cancer Database. And lastly, unmeasured factors may have influenced the decision to perform a lymphadenectomy in the moment by the surgeon. So those are some of the limitations of our study.
Excellent. So thank you for highlighting those. And I'll turn to Dimitrios for our last question. I always ask the authors of the articles that we're discussing, what do they do in their daily practice? So Dimitrios, in your practice, do you perform lymphadenectomy in patients with disease grossly confined to the ovary and nowhere else? And how about in patients with advanced disease? Do you routinely perform lymphadenectomy at the time of debulking?
These are good questions. For the second question, at the time of for patients with advanced stage disease, I did not perform any systematic lymphadenectomy. I think the Lion trial put that to rest. Of course, we do remove like any enlarged or grossly abnormal lymph nodes, but that's more a part of the debulking. And we actually did perform a prior study that showed that even for rare histologies, performing, including low-grade serous and like clear cell, performing systematic lymphadenectomy for advanced stage disease does not really improve overall survival. So for patients with advanced stage disease, even sometimes for stage with 2 disease, since it won't really change how we manage them post-operatively, they will receive adjuvant chemotherapy, they are eligible for PARP inhibitor. I do not perform any systematic lymphadenectomy in the absence of grossly enlarged lymph nodes. Now, for stage 1 disease, the short answer is yes, I do perform lymphadenectomy since it does have therapeutic implications for the patients and can guide the adjuvant treatment. However, if I have a high suspicion for granulosa cell tumor, for example, I do not perform lymphadenectomy. Or if the intraoperative pathology tells me it's a mucinous tumor, I do not perform lymphadenectomy. But everyone else, I would perform lymphadenectomy. Also, of course, the question arises sometimes when you have a patient who has been diagnosed, has had surgery with a generalist, had an adnexal mass, or has incomplete staging, would you perform take her back to the OR for a lymphadenectomy? And then it's more a discussion about like the histology. For instance, if it's low-grade endometrioid, we know the incidence is very, very low. If it's expansile mucinous, it's very, very low incidence of lymphometastase, wouldn't perform a lymphadenectomy. And for patients with germ cell tumors, for example, it may not really change whether to administer chemotherapy or not. So I take all these into consideration when deciding if I would take a patient back to the operating room for a lymphadenectomy or not.
Yeah. And Dimitrios, as an add-on to this question, surgical approach for you in your practice, open or minimally invasive?
Traditionally, it's open, but I also perform for adnexal masses that has low I do not think there will be spillage given the size of the mass. I do perform minimally invasive in the absence of any other gross disease outside of the ovary. If there is disease outside of the ovary at the time of the surgery, I do perform a laparotomy because it does give you better assessment of the extent of the disease. And for large adnexal masses, if there's like concern that there will be spillage from the manipulation of the mass, I perform laparotomy, given that spillage has negative implications for the patients. But I do perform minimally invasive staging for patients with adnexal masses. Yeah.
Okay. Well, Dimitrios, Elizabeth, thank you so much for your time, for submitting the manuscript to our journal. Congratulations to the rest of the authors as well. And it's been a pleasure speaking with you about this topic. Thank you again.
Thank you.
Thanks so much for having us.
Thank you.